Welcome to Assessing the Geriatric Psychiatric Patient in the Subacute Setting, Approach to Delirium Assessment. I am Dr. Stephen Scheinthal, Associate Professor of Psychiatry here at the University of Medicine and Dentistry of New Jersey, School of Osteopathic Medicine. This presentation is supported by an educational grant from the Donald W. Reynolds Foundation Aging and Quality of Life Program. The learning objectives for today are to describe the risk factors for acute confusion in older patients, to distinguish between appropriate and inappropriate use of psychoactive medications in a patient with acute confusion, to utilize effective management strategies in the treatment of hypoactive delirium, and to recognize the value of the interdisciplinary team in caring for patients in the subacute setting. There are several key components in the geriatric psychiatric consult in the subacute setting, and they are listed here. We will cover these in more detail. There are three essential components of the history. The review of the patient's chart, which should encompass the current course of the patient at the subacute unit. It may also have information pertaining to the hospital course, and if it doesn't, you should feel free to ask the staff if hospital records are available. Collateral information is very important, as the patient may not be able to provide you with an accurate history. Nursing, social work, physical and occupational therapy are all valuable resources in being able to put together a careful history. Family may or may not be available, and if they are available, certainly they most likely know the patient better than any of the other collateral informants. Finally, a medication review is very important. Much of the time may in fact be spent on medication reconciliation in order to appropriately treat the patient in the subacute setting. Today, we are going to look at the case of Mrs. M. The consult request comes into your office, consult Dr. Smith, geriatric psychiatry, and the reason for the consult: patient is depressed and tearful, please evaluate and treat. Sometimes consult requests come in that provide incomplete information. Consult psychiatry with no information given, patient known to you, which is not considered medically necessary by CMS. Looking back at the chart, talking to staff, speaking to your consulting provider are all helpful when the consult request does not provide any information. In the case of Mrs. M, we learned she is a 78-year-old female. She was admitted from the subacute unit 2 days ago from a local hospital for rehabilitation following right hip fracture. She fell at home. She had a hospital stay of 5 days. On hospital day 3, she became very confused and agitated. Her past medical history is listed here and may provide some clues as to what is going on with Mrs. M. Upon further review of her chart, in looking through her interdisciplinary notes, we find that nursing reports that she has been very lethargic since admission. She's not participating in her therapy according to nursing, sleeping most of the day, only eating about 50% of her meals. Social work reports that she was widowed and living alone, that she has 2 children who live out of the area and have not been very involved in her care. Up until her fall, she was very independent. She had no prior psychiatric history. She is a college graduate and a former school teacher. Social work spoke with the family, who reported that they are concerned that she is over-medicated. They reported she was never like this before, and that she had been on no psychiatric medications prior to her hospitalization. In looking through the physical therapy notes, physical therapy's prior functioning mainly is based on family reporting in this case, with the family reporting that she was living independently, fully functional, with no deficits. Currently, the assessment is that she is not ambulating. She's non-weight bearing, not participating in therapy, tearful, but not admitting to any pain. When you take a medication review, it's important to look at the current and previous medications. This is called conducting a medication reconciliation. We need to review the medications that were started in the hospital and why exactly were they started. We also take a very careful look at high-risk medications. That is, medications that have the potential for serious adverse events, medications that have a high risk of contributing to drug-drug interactions, and we need to weigh the risk versus benefit of each of the psychoactive medications that our patients are on. In the case of Mrs. M, we see that she is taking currently Ambien, glucophage, metoprolol, Plavix, and Reglan, and that she is on no over-the-counter medications. Medications that were added in the hospital include Seroquel, 50 milligrams 3 times a day, and Ativan, 0.5 milligrams twice a day. The first question we encounter with regard to the case of Mrs. M is, why is she on Seroquel? Let's take a moment to think about this. Upon review of her records, we see that she was restless and agitated on hospital day 3. A stat psychiatric consult for agitation was ordered. The psychiatrist reported the patient as having a delirium, but there was no etiology of her delirium identified in the consult. Seroquel was started for her delirium, and the hospital notes show that the Seroquel was effective in reducing the agitation associated with delirium. Personally, I always pull the patient's MAR to review medications. You may find that the MAR and the chart orders do not match. In addition, the MAR will tell you what medication the patient is getting. That is, if the medication is prescribed and the patient is refusing the medication, or if the staff are unable to give the medication to the patient because they can't swallow, it needs to be given in food. There are a whole host of information that may come out upon reviewing the MAR. In addition, talking to the nursing staff and finding out how easy it is to give medication may be helpful. In the case of Seroquel, for example, this dose was prescribed 3 times a day. Nursing staff may be actually fighting with her to take medication, and you may need to reconsider the use of a 3 times a day oral medication. The next question that comes to mind in the case of Mrs. M is, if her acute behavior has resolved, why was the Seroquel continued? Let's take a moment to think about this. Well, quite simply, the psychiatrist did not have the time to return to see the patient before she was discharged. The medication that was started for the behavior associated with delirium was just transposed to her transfer sheet and continued at the subacute unit with no one questioning the order. Hospital records are very helpful to determine why people are on medications. In this case, we know from the family that prior to her hospitalization, she was on no psychiatric medication, and that gives us a good picture of the patient's mental health prior to hospitalization. The next logical question that comes up is, what are the risk factors for continuing Seroquel in this patient? Let's take a moment to think about that. All antipsychotics carry the risk of extrapyramidal symptoms, EPS, tardive dyskinesia, TD, and neuroleptic malignant syndrome, NMS, which can be fatal if the symptoms are not identified quickly enough. In addition to these common side effects, atypical antipsychotics also carry a risk for metabolic syndrome. This is a cluster of diabetes, weight gain, and hyperlipidemia. Seroquel, in addition, carries a risk of QT prolongation. All antipsychotics, due to their sedating nature, can contribute to falls, dizziness, and orthostatic hypotension. In general, antipsychotics, despite their risks in the elderly, are the drug of choice for the agitation associated with delirium. An older name for the antipsychotic group is the major tranquilizers. They were given this name due to their sedating effect. It is the sedation that we want to use to help control the severe agitation associated with delirium. The drug of choice for treating behavior in delirium, based on the evidence, is Haldol, 0.5 to 1 milligram orally every hour until the desired sedation effect is reached is what is recommended. IV Haldol should be avoided with the exception of patients who are on a cardiac monitor due to the risk of torsades de pointe. Antipsychotics should be tapered and discontinued over a 2 to 3 day period after symptom resolution. The literature presents a wide range of dosing options for IM Haldol. Intramuscular Haldol can be safely used. It is always recommended to start at the lowest dose, 0.5 to 1 milligram every hour if necessary. Some patients, due to the severity of their symptoms, their overall body size, their prior psychiatric history, may in fact require higher dosing. Caution should be used when giving higher dosing of Haldol to the frail elderly. Atypical antipsychotics have also been shown to be effective in treating agitation associated with delirium. The drug of choice here is Risperdal. Dosing of Risperdal is recommended at 0.25 to 0.5 milligrams orally or via dissolvable tablet every 8 to 12 hours. The dose of Risperdal should not exceed 2 milligrams in 24 hours in the elderly. It is important to remember that intramuscular Risperdal is a long-acting product and it will take a minimum of 6 weeks before effect is seen with this drug. Intramuscular Risperdal is not recommended for treatment of acute symptoms associated with delirium. So, we've covered the patient being on Seroquel. Let's turn our attention to this question. Why is Mrs. M on Ativan? Let's take a moment to think about this. Her chart reflects that Ativan every 8 hours was being given for crying. Her hospital notes report that she was in fact crying and that the Ativan was started on hospital day 2. After giving the Ativan, she was much calmer with no more crying. Ativan is a renally cleared benzodiazepine, and she may have been calmer due to the tranquilizing effects of the Ativan. Ativan is not a treatment for depression. It's very important to note that patients often receive benzodiazepines for their tranquilizing effects. This class of medication was referred to as the minor tranquilizers. You should always resist using this class of medications in the elderly specifically for sedation. The adverse consequences in the elderly can be extreme. Pain always needs to be ruled out as a cause for crying, restlessness, or agitation before considering any psychoactive medication. Benzodiazepines were referred to as the minor tranquilizers. They're indicated for anxiety, as muscle relaxants, for status epilepticus, for nausea and vomiting, and for preoperative sedation. In the elderly, they carry a very increased risk of falls, confusion, depression, and delirium. And what's more, these medications are very habit-forming. In acute confusion, psychotropic medication should be reserved for patients in distress due to the severe agitation or psychotic symptoms that may accompany a delirium. Wandering would not be an indication for the use of psychotropic medication. Whenever possible, you should aim for monotherapy at the lowest effective dose and tapering off the medication as soon as possible. That is to say, if a patient is receiving Risperdal for another reason, we would not want to add Haldol for the agitation associated with delirium. In general, the antipsychotics are the treatment of choice for the agitation associated with delirium. And in general, benzodiazepines should be avoided for delirium. However, when the delirium is caused by the withdrawal from alcohol or sedative hypnotics, benzodiazepines may in fact be the drug of choice. Let's turn our attention to the physical exam in the case of Mrs. M. In psychiatry, the physical exam is the mental status exam, and there are several key components as you can see here: appearance, speech, affect and mood, thoughts, sensorium, and cognition. The mnemonic ASATS is a helpful way to remember the key components of the mental status exam. In the case of Mrs. M, we see that this is a 78-year-old female who appears much older than her stated age. She's fairly dressed and groomed. She is in bed, but she is minimally cooperative with poor eye contact. Her speech is sparse and underproductive, but she has no pressure. She reports her mood as horrible and has a sad and tearful affect. She has no evidence of suicidal or homicidal ideation and no auditory or visual hallucinations. There are no looseness of associations, no flight of ideas, no ideas of reference, and no paranoia noted. Mrs. M is alert and oriented ×2 to herself and to place, but not to date. Her short-term memory is limited, and her long-term memory is good. Her insight and judgment are reported to be fair. What is happening with this patient? Let's take a moment to think about that. Is Mrs. M suffering from a dementia, a delirium, or a depression? We're going to explore these each in greater detail. Does Mrs. M have depression? Well, she's tearful, she's not eating, she says she's depressed, she is not participating in therapy, but we have no prior history of depression. In fact, we have no prior psychiatric history per her family up until her presenting in the hospital. When we look at the DSM-4-TR criteria for depression, we would like to see 5 of the following symptoms over a 2-week period: depressed mood, diminished interest and pleasure, significant weight loss not due to dieting or weight gain, insomnia, psychomotor agitation, fatigue or loss of energy, feelings of worthlessness, diminished ability to think or concentrate, recurrent thoughts of death, not just fear of dying. What's important, though, is to take a look at the other criteria. Particularly, let's take a look at the D criteria, that the symptoms are not due to the direct physiologic effects of a substance or a general medical condition. It is the D criteria here that will prevent us from diagnosing Mrs. M with a depression at this time. So the next question that comes up is, does Mrs. M have dementia? We know she has a decline in function. We know that her short-term memory is limited, but we also know that her long-term memory is still good. When we take a look at the DSM-4-TR criteria for dementia of the Alzheimer's type, what we want to see is memory impairment along with one of the following cognitive disturbances: aphasia, apraxia, agnosia, or a disturbance in executive function. However, what we would also like to see is in the C criteria that the course of the decline is gradual in onset and continuing. In Mrs. M's case, what we know is that she was functioning fine up until coming to the hospital. We also would like to take a close look at the D criteria here, that her symptoms, as noted before, are not the direct result of a central nervous system condition such as a stroke, Parkinson's disease, Huntington's disease, subdural hematoma, normal pressure hydrocephalus, or a brain tumor. We also want to be certain that her symptoms are not caused by a reversible cause of dementia, hypothyroidism, B12 deficiency, folic acid deficiency, and we also want to be sure that this isn't a substance-induced condition. Finally, it is the E criteria that we have to look closely at, and that is that the deficits do not occur exclusively during the course of a delirium. Which brings us to this question: does Mrs. M have an ongoing delirium? She's lethargic, she has fluctuating mental status, she had an acute onset of her symptoms, and she does in fact have disorientation. When we look at the DSM-4-TR criteria for delirium, we see that it is a disturbance of consciousness with a reduced ability to focus, sustain, or shift attention, a disturbance in cognition, memory deficits, disorientation, language disturbance. The disturbance develops over a short period of time, hours to days, and may fluctuate during the course of the day. And the E criteria, that there is evidence from the history, physical exam, or laboratory findings that the disturbance is caused by the direct physiologic consequence of a general medical condition. There are three basic types of delirium. Hyperactive delirium, these are the agitated, combative, restless patients who may be hallucinating. These are very easy to recognize. These are loud, disruptive patients that frequently you are getting calls on. There is a hypoactive type of delirium. That's about 24% of all delirium. These are lethargic patients with reduced psychomotor functioning. These are often termed good patients by the staff. These are people that often we will not be asked to see because they're not causing any difficulty. And the mixed type of delirium, which is about 46%, have features of both hypo and hyperactive delirium. They're agitated and combative with alternating episodes of somnolence or hypoactivity. In looking at the difference between delirium and dementia, these may be helpful in allowing you to distinguish as you continue on in your careers. The onset of delirium is acute, while dementia insidious. Delirium may come on from days to weeks, while dementia months to years. The course of delirium is fluctuating, while dementia is slowly progressive. Attention span in delirium is poor, while in dementia it is usually unaffected. Consciousness in delirium is also impaired. In dementia, consciousness may be clear until late in the course of illness. A helpful tool to assess delirium is the CAM, or the Confusion Assessment Method. It is recommended that clinicians use the CAM for screening and as an aid in the assessment and diagnosis of delirium occurring in older patients in an acute care setting. The CAM is consistent with DSM criteria and has been validated in acute care settings, and as you can see here on the screen, has an excellent sensitivity and specificity. In assessing the acute onset and fluctuating course of a delirium, it is important to speak with a family member or with a caregiver who spends a lot of time with the patient. Listed here are 2 questions that may help you better get at the information that you will need to be able to assess a delirium. In terms of looking at inattention, you may find these questions helpful. In addition, serial 7s, or spelling the word world backwards, may also be helpful in looking at the patient's degree of attention or lack of attention. In being able to assess disorganized thinking, you should think about these questions while you're speaking to the patient. Was their thinking disorganized or incoherent? Are they rambling or having an irrelevant conversation? Are they unpredictable, switching from subject to subject? All of these feed back into disorganized thinking. In the case of Mrs. M, let's take a look at her diagnoses. On axis 1, I would give her delirium and also consider an underlying dementia not otherwise specified. We should also consider depression not otherwise specified, but we really can't come up with either of these 2 diagnoses until we're sure the delirium has cleared. We also need to consider that this is an adjustment disorder with depressed mood, given the abrupt change in her level of functioning. I would defer diagnosis on axis 2. As you know, we should not be diagnosing personality disorders based on a first meeting with a patient. On axis 3, we know that Mrs. M is status post-hip fracture, that she has a history of hypertension, diabetes, coronary artery disease, degenerative joint disease, osteoporosis, and she's had urinary tract infections. On axis 4, we know she has social and financial constraints, and she has chronic medical illness. On axis 5, at this time, I would give her a 50. When we take a look at underlying causes of delirium, the mnemonic delirium can be very helpful for you in being able to remember what areas you should pay attention to. D is for drugs. Is the patient on any inappropriate medication? E for electrolytes. Is there an electrolyte imbalance? L is for lack of drugs. Does the patient have poor pain control? Or are they in sedative or hypnotic withdrawal or alcohol withdrawal that's not being addressed or adequately treated? I is for infection. Is there an acute infection that is not being addressed? R is for reduced sensory input. Is the patient in restraints? Are they having visual or hearing impairment? Is this someone who needs glasses and the glasses aren't available, or they usually wear hearing aids and now they can't hear what's being said around them? I is for intracranial. Has the person had a seizure that's not being addressed? Is there a subdural hematoma or a stroke causing the problem? U is for urinary retention or fecal impaction. M is for myocardial. Is the patient in congestive heart failure? Have they had a new onset myocardial infarct? In addition, you should know who is at risk for developing delirium. And the list here is rather inclusive. Should pay special attention to the patients who are over 70, who've had change in their environment, who've had a recent surgical procedure, who may have pre-existing cognitive disorder, whether that is diagnosed or undiagnosed, people who have a history of psychoactive medication usage, all at risk for developing a delirium. So let's take a moment to talk about how we manage an acute delirium. Well, we want to eliminate offending drugs. the best treatment for delirium is to establish the underlying cause and then treat it. And some of these are obvious. Supportive care, though, and reorientation can be helpful to reassure the patient and to calm down agitation. Providing appropriate sensory items, glasses and hearing aids, can go a long way. The knee-jerk response is to isolate these patients, but we know that isolation can make the delirium worse. We want to minimize environmental isolation whenever possible. We want to pay a special attention to the patient's concerns and fears and be able to address them as we would want our fears and concerns addressed. Whenever possible, removing immobilizing lines and devices and avoiding restraints can be helpful in managing delirium. And of course, adequately assessing and treating pain is of great importance. None of us would want to receive a psychoactive medication when what we really need is appropriate pain medication. Let's turn back to the case of Mrs. M and take a look at the plan. First, I'd like to discontinue her Seroquel. She doesn't have any signs or symptoms of agitation or psychosis at this time, and the Seroquel can be increasing her sedation, exacerbating her diabetes, and can be contributing to QT prolongation. Frequently, antipsychotics are given to patients for sedation and may be vestiges of the delirium in the hospital. In general, while these medications are effective, they are not safe, and their usage should be kept to a minimum, especially in the elderly. Often, antipsychotics are prescribed for non-FDA indications, and while their usage in dementia with psychosis is well documented, the use of antipsychotics for sleep is dubious. I would also like to discontinue her Ativan. Benzodiazepines do not treat depression. The patient was reported as tearful. They can cause increased confusion, lethargy, falls. They can cause agitation via disinhibition, and they may increase depression. Benzodiazepines are often used for a host of reasons that are well beyond their FDA-approved indication. Using this class of medications in the elderly is fraught with problems, as we just discussed. Perhaps one of the least well understood consequences of benzodiazepine usage is disinhibition. While this class can be very effective in calming an acutely agitated patient, hence the name minor tranquilizer, over time, due to their effect on the GABA system, they can disinhibit the patient and actually lead to increased agitation. When considering prognosis and follow-up for Mrs. M, it's important to note that it will take 7 to 14 days to allow the medication to wash out of her system. Mrs. M does not have a prior psychiatric history, and this is a good prognostic indicator for her. There's a greater likelihood, because she has no prior history, that she will in fact return to baseline. We should avoid temptation to treat the side effects of medication with more medication. This is called a prescribing cascade. We cannot determine if she has dementia or depression until her delirium has resolved. Please take a look at the following pearls. The underlying theory holds that less is more when working with an older patient. Just because the patient is taking a drug does not mean that that drug should be continued or is working. Drug-drug interactions can wreak havoc on the older patients. Medications may in fact work unpredictably in the older patient. Don't forget that in general, pharmaceuticals are studied in younger, healthier patients than we see in a delirium consult. Studies do not take into account the changing physiology and multiple drug regimes of the patients that we see and treat. Not every behavior can be solved with a medication. Be very careful about the do something phenomenon. Think about why you're prescribing a medication to a patient. What is the goal that I am trying to receive? What symptoms am I hoping to change? Am I just treating the side effects of other medications with more medications? For example, in the case of Mrs. M, a stimulant to increase her lethargy may only be treating the side effects of the Seroquel or the Ativan. I hope that this presentation was helpful and will increase your knowledge as you continue to care for your older patients.